Bueno, muchas gracias a todas y todos por conectarse eh, súper a tiempo. Son las 10:05, te damos como unos 5 minutos para que la gente se pueda conectar. Y bueno, estamos muy agradecidos de que en nuestro seminario de este mes nos va a acompañar Luke Allen y nos va a hablar de este estudio que hizo acerca de cuáles son los factores geopolíticos que permiten que pues sí, se incorporen las medidas recomendadas por la Organización Mundial de la Salud para abordar las enfermedades no comunicables. Y digo, ahí veremos ciertos puntos de reflexión interesantes para nuestro país. Luke es médico, practicante, y también es un analista de salud global, y se formó en la Universidad de Bristol. También se formó en la Escuela de Salud Pública de Harvard, la Kennedy School of Government, el MIT y Oxford. Su investigación está enfocada en el avance de la atención primaria mediante la integración de la salud pública y la atención primaria, con énfasis especial en prevenir enfermedades no transmisibles. En su cargo actual, utiliza la investigación acerca de aplicación y diseño de diseños adaptativos para optimizar un programa de tamizaje oftalmológico en Botswana, Kenia y Nepal. Él codirige el grupo de atención primaria de LSHTM, de la London School of Hygiene and Tropical Medicine, y los seminarios mensuales de atención primaria de la salud de la escuela con Luisa Pettigrew y Joe Exerly. Les voy a pasar el link de los seminarios de atención primaria porque están buenísimos, ya que sí terminan. De hecho, pero a lo largo de un año estuvieron haciendo unos seminarios muy, muy interesantes de cómo eh, pues, avanzar la atención primaria. Luke tiene una amplia experiencia en política sanitaria mundial y ha trabajado con la Organización Mundial de la Salud, el Banco Mundial, el Harvard Health Systems Cluster, Public Health England y la Fundación Bill y Melinda Gates. Ha asesorado a gobiernos de países de renta alta, media y baja. Completó su beca clínica académica en Oxford y sigue trabajando en la ciudad como médico de familia a tiempo parcial. Es miembro de la junta directiva de la RCGP Thames Valley Faculty y del consejo editorial del British Journal of General Practice, la revista de atención primaria mejor clasificada del mundo. Dirige a nivel internacional el grupo de interés especial en atención primaria y salud pública de la Facultad de Salud Pública. Luke también es director de Healthier Systems, una consultora de investigación sanitaria. Sorry?
You've got to stop. This is too much.
Well,
this is my
sorry.
life story.
Yeah, sorry, Luke. So, well, yeah, I'll just give you the link. But, well, thanks for being with us.
It's an incredibly generous and very long introduction. Thank you. Muchas gracias, Daniel. It's really, really lovely to be here with you. Yeah, apologies for if I sent you a bio that was 15 pages long. But yeah, it's great to be with you all today. So yeah, we're just going to be talking through a paper that came out in the Lancet Global Health several months ago now, and I've got a QR code there if you're that way inclined, and I'm just going to post in the chat the link because I don't want to bog you down in the methods too much. I'd like to get into the juicy discussion bits if we can. So this work was, I was the lead author, but Dr. Hampus Holmer from the Karolinska Institute, Dr. Pepita Barlow from LSE, London School of Economics, and Professor Simon Wigley from Bilkent University in Turkey all did all of the hard work. I just did a bit of typing at the end. So where are we going? Give a little bit of background to the project and non-communicable diseases, talk about the WHO best buys. I might just ask now, can you just stick a thumbs up if you've ever heard of the best buys, or a thumbs down if you never have? Thumbs up, thumbs down, and I can only see the two of you, so I'll go with 50-50 there. Okay, the aims of this project, what we found, and then we'll have some time for discussion at the end. So non-communicable diseases. I've got, say, a forest plot here from the Institute for Health Metrics and Evaluation based in Seattle, and they've plotted all of the disability adjusted life years in the world and the conditions that they're attributable to. And everything in blue is a non-communicable disease. So you've got ischemic heart disease in the very top left, stroke, lung cancer, COPD, diabetes, they're the big squares there. And the share of all DALYs and also for deaths attributable to NCDs has just been growing and growing and growing over time, far overtaking injuries down in green and violence, as well as neonatal, maternal, childhood and infectious diseases in pink. The shading of each square relates to whether prevalence rates are going up or down, and you can see HIV compared to 1990 is still on the way up, but actually we've probably passed that inflection point, and the rest of those groups in red are pretty pale. In high-income countries, NCDs are responsible for about 80% of all deaths, and that's pretty stable. A much lower share in low and middle-income countries, but they're the countries that are seeing the fastest increase in these conditions. And health systems aren't necessarily set up to manage them well, so it's a big problem. Does it matter that 70% of all deaths are NCDs? I think probably in an ideal world, 100% of deaths would be from NCDs. I want to die in my bed at age 85 from a heart attack. They're only really a problem when they strike young, and can be associated with lots of morbidity as well. So what we're in the business of is preventing premature mortality and morbidity from NCDs. Been pretty neglected by WHO for years and years. They weren't in the Millennium Development Goals. Bill Gates doesn't really give them very much money. And that's true even today. They, as I say, responsible for 70% of global burden of disease. They receive less than 2% of all funding. So despite the fact that they're increasingly talked about in policy circles, resources still are not flowing towards them for a wide range of reasons I'd be happy to discuss later on if that's where the discussion takes us. So in 2010, WHO produced a set of policies, a menu of policy options that quickly became dubbed the best buys. And these are highly cost-effective interventions for addressing non-communicable diseases. And they are very cost-effective in low and middle-income countries, which was deemed to be the countries that needed the most support. There are 19 of them. I've got 2 pages. So we'll just hang on this one for a bit, then I'll flick through in a second. Broadly speaking, they are around policies, guidelines, and data collection, and then clusters of policies around tobacco, alcohol, diet, and physical activity. So the 4 main risk factors that are responsible for driving lots of NCDs. And the main non-communicable diseases are cardiovascular disease, cancers, diabetes, and the other one, chronic respiratory diseases. All right, mental health and air pollution are another 2 important conditions and risk factors that have only recently been kind of introduced into this framework. Okay, so they're the first 10, and here are the remaining 9. So all of these are population level interventions, bans, and taxes, and campaigns and promotions. And then right at the end, we've got clinical guidelines, and we've got drug therapy. And I'm a GP, so I do clinical medicine, but I've studied public health enough to know that what we really care about are these great big population level policies, because they actually work on the population level and are associated with much fewer socioeconomic inequalities. So what's interesting is that WHO have said for years countries should be thinking about introducing these, and all WHO member states repeatedly have signed up and said, yeah, we endorse these policies. And every other year since 2015, WHO has been doing surveys to work out how many of these policies are actually being implemented in each country around the world. And using that data, we had 3 aims. So the first was to kind of look at the trajectory of policy implementation to see if it's going up, is it going down, what kind of level is it at? And this paper's the 3rd or 4th in a series that I've done. So every couple of years, a new policy a new review comes out, and we'll spit out another paper. The second bit is to look at sales of tobacco, alcohol, and junk food, because the last 2 were 2021 and 2019, so before and after the COVID pandemic. We wanted to see if policymakers were introducing policies quickly in response to changes in consumption habits. And that was really driven by the observation that some countries had massively clamped down on risk factors. So in our country, Boris Johnson came down with COVID and was admitted to ITU and was telling everyone about how important it was to eat healthily and lay off the junk food. I think Botswana banned alcohol sales for a while. South Africa banned the sale of tobacco. We just wanted to make sure that we captured these big swings in consumption and to see if there was an association. And the third bit was to see if implementation of NCD policies was correlated with this measure that our group had previously devised called the Corporate Financial Influence Index. So we've rated every country in the world in terms of how easy it is for corporations to exert financial pressure over policymakers and policymaking institutions, i.e. lobbying and a bit of bribery to get them to go easy on their sector. And we wanted to see if countries that had fewer protections against these things were also least likely to have implemented policies around those products. So that's what we set out to do. In terms of our data sources, they're all very colourful. So on the right here, we've got the 4 NCD progress monitor reports that the WHO put out in 2015, 2017, 2019 and 2022, each of them reflecting data collected in the previous year. And then we had sales data from Euromonitor International, and then the Corporate Financial Index came from VDEM project, which again we can talk about later if you'd like to. It's well worth having a swim in their website. They gather all sorts of bits of interesting data on democracy and lots of other social factors and compile them all for researchers like you and me to use. Let's jump into the findings. So first bit, trends over time. We found that implementation started pretty low, has increased up until 2019, and then stayed completely static between 2019 and 2020, with 47.8% of all policies implemented by all countries around the world. With, as you can see from these violin plots, which are the most, not to be too crass, but they look like vulvas more than any other plots I've ever seen. The distribution stayed about the same and is pretty broad. The interquartile ranges for the last 3 sets of these are pretty equivalent, aren't they? And is it surprising that policy implementation stalled? Yes and no. Again, we'll talk about this at the end. I was expecting to see an uptick in countries that had introduced emergency measures that was going to be reflected here. The other thing to say is that it's been it's been over 10 years. It's been about 13 years since all countries in the world committed to introducing these policies, and still fewer than half of them have done so. So that's slightly damning, isn't it? Next set of findings was around regional variation. So we just looked at mean implementation in 2014, dots on the left, and then plotted them again in 2021 to look at how things have moved over time. And we saw that countries with the overall highest levels of implementation, so the darkest dots in 2021, tended to be Europe, high-income countries, the OECD, the EU, and former Soviet states. Interestingly, countries that used to be in the USSR have just got a really strong record of implementing population-level policies. That's partly what's driving the WHO region's high performance at the top. What sticks out as doing particularly badly? Well, fragile and conflict-affected states and small island developing states tend to be doing less well in terms of implementing these policies. And we've actually seen quite large gains in the EMRO region. And where's Afro gone? Yeah, Afro is not doing brilliantly either. The next thing we did was just break up those 19 policies and look at how changes in individual policies had varied over time. So for each policy along the left, we've got these columns going from 2014 to 2016 to 2019. The last column shows what happened in 2019. And everything on the right is where the score in 2019 was better than the score in 2021 was better than the score in 2019. So this is where policy implementation has gone up. And the biggest difference there, clinical guidelines saw the greatest increase. Alcohol taxes, there was no change. And down this other end, all of these policies are dropping down in the last 2 years. So mass media campaigns to tell people to get active just fell off a cliff between 2019 and 2021. I guess that makes sense, doesn't it? If everyone's stuck in their houses under lockdowns, there's probably guidance saying don't go out, as opposed to go out and get active with your mates. What else is interesting here? So the overall, tobacco policies are doing quite well. They tend to be on the right-hand side with increases over time. However, lots of them are still at relatively low levels. So starting from a low baseline, but moving in the right direction. Alcohol policies are either standing still or going in the wrong direction. And that's been going on for a long time and is slightly worrying. What's doing really, really well? What's this? Plain package graphic warnings on tobacco. It's encouraging and surprising. I guess that's the FCTC doing its job. Clinical guidelines, national NCD targets, plans risk factor surveys, mass media campaigns. So broadly speaking, these kind of things that do relatively well don't conflict with corporate interests, and quite a lot of them you just need to like write a plan in the Ministry of Health and stick it in a drawer. You don't actually have to do anything particularly difficult. That's possibly, I speculate, what's going on there. Whereas taking on the alcohol industry or making people reformulate their salt policies or that kind of stuff, you've got vested powerful interests that you've got to deal with. Okay, next finding is about how sales of certain goods changed before and after the pandemic. And we split them up. So here are the different products. And then we've got high income countries, upper middle income countries, low and lower middle income countries. And these two are basically the same. So LMICs. For the sake of comparison, I want you to focus on these two. And just note that for most products, there wasn't really much of a difference at all. Only a few right at the top and at the bottom. And sales changed for cigars and cigarillos, more being bought in high-income countries, whereas cigarettes, a non-significant drop there. Baked goods and beer seeing significant drops, as well as sugar and sweeteners, and almost the exact mirror image happening in LMICs. So cigars and cigarillos dropping there, ready meals dropping there, and baked goods and beer going up on the other side. No idea why, and our study is not set up to explain what's going on there. So you can ask me all you want, as peer reviewers tend to do, but I can't tell you what's going on there. The next thing we did then was we took the categories where there were swings in each country, and we looked to see if sales of cigars and cigarillos have gone up. In those countries, have policymakers responded by putting or enforcing policies around these products? And by and large, the answer was not really, no. So countries that saw increases in the sales of alcohol had no difference in terms of whether or not they were likely to introduce new alcohol restricting policies. Junk food, there are a number of negligible associations, but nothing to write home about. And yeah, so tobacco, there are a number of different products. And for cigars and cigarillos, we did see that for every 1 unit increase in sales, there was a 0.1 percentage point increase in implementation. But again, that's not encouraging, but not amazing, really, is it? Just 2 slides left from me, okay? So the last piece of the analysis that we did was around corporate financial influence. I've got a lovely scatter plot here. So on the bottom, on the x-axis, we've got corporate financial influence index, and countries on the far right-hand side, it's a score out of 100, like Saudi Arabia, Qatar, and Eritrea, have got basically no legal protections that stop lobbyists from spending money on getting policymakers to do what they want them to. Down on the far end, we've got countries like Lithuania, Estonia, France, Belgium, South Korea that have got lots of regulations in place. And this composite index is made up of 6 things. So does the country have regulations in place to make sure that they disclose all campaign donations? And public campaign finance? Is there a ban on corporate campaign donations? Do you have to disclose financial and business interests if you're a politician? A measure of the amount of corrupt activities in the legislature that have been reported by VDEM, and the level of executive oversight. So we bunged all of those into a model, which gave us this overall score. And what you can see is that there's a correlation. So this is the Pearson's correlation coefficient, so that the countries that have the highest levels of corporate financial influence, or opportunities for corporate financial influence, tend to have the lowest implementation scores. So they're the least likely to have implemented policies that restrict the sale of unhealthy commodities. And we did this for all 19 policies, and we did it again just for the policies relating to those commercial determinants, and it gave us pretty much exactly the same picture both times. And we also found that corporate financial influence explains about 23%, so just under a quarter of all of the variance in the scores across all countries. So this measure is significant and is explaining quite a lot of what's going on at the moment, which is important because not a lot of the kind of established WHO policy on addressing NCDs focuses on tackling corporate activity and what's going on there. I think increasingly it's in the public domain. We're aware that it's an issue, but it's not yet been codified in terms of policies, approaches, strategies to address it. And moving on to the discussion, maybe if I just continue that thought, a recent series of WHO reports on NCDs increasingly are asking member states about what their concerns are, and reporting that one of the main concerns from member states is they're facing lots of pushback from industry and are increasingly asking for technical assistance in addressing it. And I'm involved in the upcoming WHO and World Bank joint report on NCDs, and trying to make sure that this is something that gets some airtime in there as well. Okay, so these are basically my take-home messages, and then I'm going to stop screen sharing and open up questions to the floor. But so I've shown you that progress has stalled at about 48% of all policies. I guess the question is, what's going to happen in the next couple of years after COVID? Was that a temporary blip and the same slow trajectory will continue, or will things move down? So I'm interested to see what comes next. Tobacco policies are on the up, which I think is really, really encouraging, because it's the leading cause of death in terms of risk factors in lots of countries around the world. But it's starting from a low base and still insufficient. Alcohol policies everywhere are doing pretty badly, and I don't really know why. I think that there are repeated calls for something like the Framework Convention on Tobacco Control for alcohol and for junk food. One of the things that muddies the waters a bit is that tobacco is unequivocally bad for you, but the public health community hasn't been particularly consistent in our messaging around whether all alcohol is always bad for everyone at any dose, right? My personal take on the evidence is that there isn't a safe level of alcohol consumption, but yeah, we can talk more about that. And then diet as well. There's no such thing as unhealthy foods. It's unhealthy diets. Again, there's pretty good evidence that ultra-processed foods don't do any good for you. I found it interesting, people saying, well, you still can't say they're bad, because if you were starving on a desert island and all you had was a chocolate bar, you know, that's good for you because it's going to stop you dying. But definitely policy making here, it needs a lot more nuance. Okay, this bit here about short-term sales fluctuations. Yeah, they didn't register in terms of, even in countries where sales of alcohol went up, policymakers didn't introduce policies. Why? Well, it takes time. It takes time to introduce policies. If you're in China or quite an autocratic regime, you can introduce policy very quickly, but in messy democracies, it can take ages. And in dysfunctional democracies, which is pretty much all democracies these days, you know, that process can be quite protracted. And so it's probably unsurprising that we didn't see changes reflected instantly. And it takes a number of years often for these things to get reflected. Penultimate point, regulatory protections against industry are important. And that's what I was talking about as we came into this slide. And just finally, to end on the main limitation for this piece of work, we're talking about correlations here, not causality. And also we're completely dependent on the data that's been presented. And Euromonitor is pretty good, VDEM's pretty good, but the policy implementation comes from WHO, who do a fantastic job, but it's self-reported surveys. So every couple of years, they do something called the WHO Country Capacity Survey, and they give a piece of paper to someone in the Ministry of Health responsible for NCDs and say, please fill in this list telling us if you've implemented these policies. And so if you're in, let's say, North Korea and decide that you want to say yes to everything, or Iran always does brilliantly, WHO does say that it goes back and double checks, but it doesn't tell us how it does that. So it could be that some countries are better or worse. And actually, I think Iran are genuinely introducing those policies. And a kind of a sub bit we did that you can see in the supplementary materials is we engaged with our colleagues at a civil society group and just had some of their members in each country kind of double check the scores. And they were broadly all right. So we've got a reasonable degree of confidence in what's being reported. So that's not 45 minutes, but I feel like a lot of talking from me, and I'm going to stop there and just open to the floor.
No, thank you so much, Alan, actually, for leaving so much time for discussion, because that's always where we have to cut like the conversation. So thank you for this very succinct and brilliant presentation. So whoever wants to speak, just like unmute yourself or put up your hand and go ahead with your questions for Luke.
Thanks, Daniel. Thank you, Luke. This is fascinating. I'm Abril. I'm a research professor at the ELTEC as well, affiliated at the School of Government and the Institute for Basic Research. And my background is in health policy implementation. I find your work very fascinating and very relevant. And I work for WHO, so I know of the best buys, etc. So I'm sorry I didn't get to read the papers. I'm going to ask you perhaps a bit more on the methods. And I was curious about the implementation score. It seems like, do you have it by policy and then you have an aggregation? And I was curious about when you talk about an implementation score for a policy, can you tell me more about how you build that? You know, because I'm very interested in your definition of implementation, because sometimes I think we confuse adoption with implementation. So I would be curious to hear more about that. And just the second point or question is about the cases of reversal. I think you have in that graph cases where like the 2021 data showed that there are less countries implementing a certain policies. And did you find cases of specific countries going back? So yeah, just eliminating policies and what are those? So thank you.
So in the supplementary materials, we've got a great big table that has every policy for every country. I'm 99% sure we do, and if we don't, I can fish it out for you. And we just didn't have the words to pick out individual countries, but we deliberately put that in so that you can go and find your own country. And I don't think I picked out Mexico actually in that graph as well, but you were doing really well for corporate financial influence, which I don't know, take that as you will. In terms of policy scores, so picking up where I left off, you give a piece of paper to the Ministry of Health and you say, have you implemented this policy? And for each one, they either say, we have fully implemented this policy, we have partially implemented this policy, or we haven't at all. And WHO turns that into an icon, like a circle, either half filled, fully filled, or empty. And we turn that into a score of 0, 0.5, or 1. And then for each country, we just add it up. So if you'd fully implemented each policy, you had a score of 19. If you'd half implemented all of them, so you're treating all of them as equivalent, and you're treating 2 half implemented policies as equivalent to 1 fully implemented. So that's weird, right? They're not equivalent, but hey, and by just presenting all of the data, and it's all there in the WHO report as well, you can dive in to find what's being done. Slight methodological issue is that WHO also reports, or we scored 0 as well, countries where there were no data available. And our reasoning there was, if you've got no data available, it's much more likely that it's not implemented than you've implemented a policy, but you don't know if you have. It doesn't get around the very tricky problem that you rightly mentioned, that implementation is different to adoption, right? And I think there are countries that have got a policy on the books, but in practice is that being, and then enforcement as well, right? You can still buy illicit tobacco, and you can still find like advertising all over the place, even in countries where officially it's banned. Both things are banned. We're quite a long way away, and I think, as you know from the Best Buys, you're not going to get that level of granularity. So this is pretty much a ready reckoner. It does also mean that we've got 2 different metrics that we're reporting. One is the kind of score for each country, and so that's what we regress against things like corporate financial influence. So how well has your country done? What number of policies have you implemented versus the regulatory protections you have? But then for each policy, it's something different, and that's where we've taken if you think about it in a table with countries in the rows and policies along in the columns, at the end, the totals of the rows, that's our kind of score for each country. But at the bottom of each column, you can also count up how many 1s and how many 0.5s and how many 0s there are to give you basically a score. And what we did was we scaled that from 0, which would be if none of the countries have implemented anything, to a maximum of 1 if all of the countries had implemented all of them. And so we just took a mean of them, and it gives you something where most of them are about 0.5, right? And so that's what we use to present those scores in that bar chart, kind of the stack bar chart that we had. Okay, nerdy question, but important. Yeah.
Thank you.
So, well, someone else, thanks for the question. I wonder if you tested to see if exactly just something that you just mentioned, if highly autocratic countries that have a communitarian or community approach instead of individualistic, if that could have an effect or on having like a more implementation of policies or not.
Yeah, it's something I'm really interested in. And the first ever study that we did probably came out in 2016 with a slightly different group of collaborators, set out to look at kind of autocracies versus democracies. And what we found in every iteration is that countries rated as being democracies by things like the Economist Intelligence Unit and the Varieties of Democracy Project, and there are a couple of more, a couple of others. However you define them, democracies outperform autocracies. Interestingly, in COVID, I remember a editorial by Richard Horton where he was saying, hey, guess what? For the first time ever, autocracies have outperformed democracies in terms of their responses. This is where, mainly driven by China really quickly, getting everyone indoors. But as time's gone on, actually, kind of, how do you score how well your country's done against democracy? But the people that look into them, and most measures show that actually probably democracies have done better in the longer run. And so in this study as well, we break apart true autocracies, democracies, and then kind of a range of countries according to the level of participatory involvement in governance making. And there seems to be a difference. Yeah.
Great, thanks.
Again, we don't know why, but we've got pretty good guesses, don't we? So in democracies, at least on paper, you're all responsible to, well, you've got to get voted in, so you've got to do stuff that's popular with your voters. You're kind of you're directly accountable in a way that you're not in an autocracy where you can screw people over and they're not going to kick you out of power. It's obviously not that simplistic, but that's probably the basic mechanism.
Great, thanks, Luke. And we have a question on the chat. So Claudia is asking, what potential strategies or policy measures could be recommended to further strengthen protection against corporate influence and ensure robust policy implementation to address NCTs?
Yeah. So that's a really good question. It's one that's I spend lots of time thinking about. So this field, the commercial determinants of health, and thinking about how individual corporate actors influence decisions made by individuals, and the wider narrative around companies trying to put the responsibility on you and me. So if I decide to drink a Coke, that's purely down to me. And if I develop laryngeal cancer further down the line, or diabetes or whatever else, that's my bad. Versus a more upstream, what are the social determinants of health that maybe shape and constrain the decisions that I make at the individual level, and who holds ultimate responsibility for those decisions. That debate about where responsibility lies really shapes the regulations that are introduced at the national level. And that in turn is influenced by the level of kind of solidarity and the kind of values that societies have in terms of whether they put responsibility for things in a highly kind of libertarian way. So people should be free to make silly decisions and do whatever the hell they want and bear the full costs versus, for instance, USA would be like our prototypical example there. I should be able to drink leaded paint if I want to, hey, versus maybe Scandinavian countries where people are willing to trade civil liberties for the benefits of the broader collective or whatever else. So those societies tend to be have a higher tolerance for introducing more restrictive policies. For instance, they would be early adopters of taxes on fats, or mandating that you've got to wear seatbelts in cars, or that you can't smoke around children. That's what goes into it. What should we be doing? That quote, the future is already here. It's just inequitably distributed. There are lots of countries already doing very good things to try and stop companies from doing very bad things. And they're very simple things like having a register of lobbyists, having politicians disclose any financial, any money that they receive from countries, and rules about campaign finance, donations. And it's basically transparency around what corporations do in a given country and how much of their financial things they have to publish and make publicly available. In terms of providing support to countries, lots of countries are facing exactly the same issues, which is that for instance, in Portugal, the Ministry of Health even wanted to introduce a policy around the amount of salt in bread, right? And had stiff opposition from a load of companies that brought a complaint to the European Commission saying that you're contravening competition rules. The same issue has been faced by lots of other countries, and I think there's a real role for just developing kind of forums where policymakers can get together and say, hey, Philip Morris is trying to like have a go at us with this new through what can we learn from what's happened in your setting. And I don't see a lot of that, and I see increasing calls for more of it. I think that would be quite easy to do and plays to the strengths of WHO, which is a very overstretched organization with a very small budget, where its core value add is that it's a relatively neutral convener and is able to bring countries around the table to discuss stuff. So I think that's a major role that I'd like to see pushed moving forwards, bringing countries together to learn from each other and share kind of best practice in how to push back against companies which tend to play from the same playbook that they've been using with tobacco since the 1950s.
Yeah, a kind of like a follow-up question. Do you see, because finally, you know, like corporations, well, kind of are directing the world, you know, in every way. So do you see that there's or have you heard of any country where there has been a like this alliance or synergy between industry and policy implementation, and that actually that has benefited the health of the population? Do you think this is an option, or well, it just should be just like industry bad and public health is like on the other side totally?
Yeah, that's a great question. So the key word that is nuance here, right? Tobacco and firearms unequivocally bad, right? But as I've said, other things, who knows? Or they might be a bit bad. But then individual companies like Coca-Cola, yeah, they make Coke. That's like tends to be a poster boy example for an unhealthy commodity. But Coke's only a part of their portfolio, right? They sell fruit juices and water, like they sell a lot of water. So just branding Coke as bad is a bit overly simplistic. The same is true for Kraft Foods and Unilever, these massive corporate giants that have huge portfolios. And even if you pick Philip Morris, that is a tobacco company, what is their impact on humanity in the world? Well, it's mediated not just through the health impact from using their products, but also how much tax they pay, and are they building roads, and are they employing people, and what are the working conditions for the people employed in those sectors. It's still probably negative for something like tobacco, just because so many people die, and also big corporations tend not to pay a lot of tax. But just saying all industry is bad, which I think is where the public health communities come from, is overly simplistic, and we need to be moving away from that to which bits of industry are bad and need to be contained, and which bits of industry and which industries and which actors and which products are good or neutral. And how can we harness and work with those areas where there's synergy whilst protecting ourselves from undue influence with the bad? Can I think of examples of where that's worked well? Again, the prototypical example is the UK's experience with salt. And we had a policy under a Conservative government, so more right-wing, more and pro-business, where the government sat down with the Public Health England, as it was at the time, and introduced industry into the equation as well, to have a discussion about how could we get salt consumption down. And it led to a voluntary industry-led reformulation strategy, where industry put forward some targets and committed to meeting them over time to reduce salt consumption. And it worked, and salt consumption dropped significantly in the UK. That's great, and is cited all of the time by industry and people who believe in partnership as like, great, we should do this. The issue is, as far as I'm aware, it's never been replicated successfully. And almost every other time industry is invited to the table, they screw things up, right? And again, I've just said nuance there, but if industries around the table with public health, and what public health wants is for fewer people to be buying your product. That directly opposes your goals of selling as much of that product as you can. There's synergy if you realize, okay, people are wanting to be more healthy, so actually by reformulating Coke and bringing out Coke Zero, we could increase sales, right? Because the profit we make isn't necessarily predicated on the health profile of a product, so there is room for maneuver there. But generally, if you bring industry in, they'll try and forestall or dilute whatever measure it is that you're trying to introduce. And there are tens and tens, probably hundreds of examples. And lots of people have written loads. I've written book chapters on of case studies of where this has happened. Examples from Canada, examples from Argentina, examples from China. Even though on paper it should be perfectly possible to get synergies, generally it doesn't work. So where do we go from here? We got to proceed with an abundance of caution. Yeah.
Thank you for that answer. We have another question in the chat. So Linda is asking, well, first thanking you for this insightful presentation. And she says, as we know, the COVID-19 pandemic has significantly affected all areas of global health during 2020 and 2021. How do you think this pandemic has influenced or altered the policy implementation regarding NCDs during these years? Were there noticeable shifts in trends or priorities due to the pandemic?
Yeah, so Linda, I partially answered that in the presentation. So I was showing you how trends have changed before and then immediately during the peak of the lockdown. So 2021, those data were reported. And we could see that things just flatlined. Your question is probably getting to what's the aftermath of COVID and the new normal, and we don't know. And part of that discussion slide I said was that I'm really curious to see in the next few years whether the current trend of kind of slow increase across the board-ish for most policies will continue, or actually if COVID will have marked an inflection point and priorities have shifted. I can talk to what's my view of what I see of what policymakers are thinking now. And definitely early on in the pandemic, there was greater attention paid to NCDs because they were such an important risk factor for poor COVID outcomes. We saw that people who were obese, people who smoked, people who had diabetes, people who had multimorbidity had much worse outcomes in terms of hospital stay, death, and other hard endpoints. And so lots of public health people and health ministries, it lit a fire under them, say, oh my gosh, we really need to deal with NCDs, make sure that the prevention agenda is being taken care of. And I mentioned Boris Johnson and talking lots about obesity and diet. We've actually seen that policymakers have quite short attention spans, and my view is that that's actually faded, and much more of the emphasis at the moment is around health security, and bound up with planetary health and stuff around migration health, violence and conflict, and what's happening in Ukraine has really captured the policy dialogue at the moment, and NCDs tend to be kind of slipping away. I'm a GP and I work lots on primary healthcare, and I've been glad to see that, again, a bit like NCDs, a slow burner rising up in the agenda, and actually NCDs as a major part of primary healthcare is often where they've been popping up in the policy debates I've been a part of in the last 6 months, let's say. But I feel like it's a much lower political priority at the moment. And yeah, it's often it's talked about a lot in policy documents, but the funding just isn't there. And I think, yeah, again, when I think about where research funding is going, I'd be interested to hear your views here, but in the UK at LSHTM, funding's not going towards implementation research, policy research around NCDs. It's going towards lab studies and preparing for the next pandemic, which is fine. That's appropriate. But NCDs do kill 70% of everyone, and I would quite like that they get at least a bit of attention.
Thank you.
Thanks, Luke. Anybody else has any question? Carolina, Berenice, David, just unmute yourself, Berenice. Go ahead. Cannot hear you. At least I cannot. I think there's something going on with your mic. No.
It looks like you're not muted, but just your microphone's not working.
Exactly.
Okay, I will work on this. Perfect, thank you. Luke, thank you for this presentation. It's very interesting. And I just have some questions. If during this study, you were able to have some insights about which was the role of the communities and how these communities evolve in the implementation of non-communicable diseases. Specifically, if there are some strategies prepared by the community in these initiatives that have been proved being effective in addressing NCDs.
Yeah, thank you. But the short answer is no. So this study looks at data from the national level, right? So first of all, and then it's looking at national policies implemented by governments. And they're things like taxes and bans. So not stuff that the kind of thing that a community would do. So no, we didn't, and we're not set up to do it. And it's not something that WHO or other, I keep talking about WHO, other international organizations are available. WHO is the most active and tends to be pretty representative of what's happening at the World Bank and other places. To my knowledge, none of them are reporting routinely in directly comparable ways what communities are doing to address NCDs. However, and again, related to the primary healthcare agenda, of which community engagement empowerment is like the third pillar, that really important, it is getting an increasing amount of airtime. Do you know, I see individual studies come up of community-based interventions or participatory action research in a given country quite a lot, but I haven't seen kind of systematic reviews or using the same intervention across multiple different countries, those kind of global level analyses, which is the area where I tend to do most of my work. So I know this stuff is happening, but I don't know at all at the global level or at the aggregate level what works in general and could be applied across countries, although there's a lots of specific, this intervention worked in this specific community for this specific risk factor. And you need both, right? I think it's probably easiest, as I said, it's very easy to write a policy on something, so unsurprising. It's a bit harder to ban tobacco, right? It's even harder to get your, well, it's probably less hard, but it's very complex to put in place effective interventions that empower communities to address these things at the local level consistently in a way that doesn't exacerbate socioeconomic inequalities. But that's really, really important and a major area that I think is neglected and a big gap that I would love to see filled.
Thank you, Luke.
Yeah.
So that's a research opportunity, Berenice, to work on. Anybody else has a question? Well, I do have a question. To measure the impact, what was the time lag that you defined between the implementation and the sales? The sales, but then another question in that sense is, why focus on the sales and not on the health outcomes? I guess it might be because you have the numbers on the sales first, it's easier to get them, but maybe there are some countries that have, demographic health surveys, et cetera, that you can look into health outcomes.
Yeah, good question. So my colleague Pepita Barlow led this analysis. I cannot remember, Daniel, I'm so sorry for the life of me. I don't have the answer for your first question, except for to say that the change in sales data, the endpoint preceded the policy implementation to give a bit of a gap, right? But I think it was reported in the same year. So we're only giving policymakers a couple of months at most. I think it was, I can't remember the exact gap that there was to act on that and then implement policy. The reason that we looked is because there are 6 or 7 countries that did almost within 2 weeks of kind of declaring COVID a major thing, banned tobacco or the sale of alcohol. South Africa banned the sale of tobacco for 20 weeks and then you could buy cigarettes again, but in that time prevented 2,300 deaths. Absolutely incredible.
Yeah.
Why did we look at sales data rather than health outcome data? Because it's a proximal outcome. And because we only had that short gap between the change and implementing policy, there's a long time lag with the change in sales to lead. We haven't, South Africa modeled that 20-week thing would have led to a reduction in deaths, but would be waiting 20 years to find out what happened. So that's why we looked at at sales data there. And in a previous paper, in fact, this same paper, but from 2 years ago, and every year we do something slightly different, myself and Hampus and Simon, with a colleague called Martin McKee, who's a very senior professor at LSHTM, developed a conceptual framework on how, what factors influence NCD policymaking. And it starts with very broad things like your socio-historical context, right? If you're more right-wing or left-wing, your GDP, the capacity of your Ministry of Health, and then your political priorities. But two of the things that, so broken into your means and your motivations to act, right? Means you've got to have a competent legislature and Ministry of Health with civil servants and some money. But their motivation's a bit different. So that's where lobbying comes in, the individual policy goals of politicians. But then two other things that feed in is, one's around sales and like, how much is this risk factor an issue in my country? Are sales of tobacco / tobacco prevalence rates through the roof? Or let's say alcohol, it's just alcohol consumption is just not really an issue for lots of the Middle East. So there's not a lot of motivation to act. Another thing is deaths from those NCDs, right? And in each country, for every policymaker, the relative importance you give to these different things differs. And there's a great paper by Swift or Redman, I can't remember, looking at the different things that policymakers take into consideration when deciding whether or not to act. There's a huge literature on this, right? But we, from the public health community, we tend to think, oh, they just look at the evidence. And then no, of course it's not that. It's, what do my constituents think? What are the interest groups? What am I going to get into office? What do I care about personally? What did my husband talk to me about last night? I've got to impress my boss. What do they care about? And within all of that, what smoking rates and then how many people die of lung cancer are two things feeding into death rates and sales. And they might be different, right? And it depends on trends over time. So yeah, what we can do, we haven't done all of this, but we could do next time, or you guys could go and do, is you could look at, for a given country, what's happening with implementation of tobacco policies at the national level and the community level, if you want to, Benedis. Then you could also look at tobacco smoking rates over time, which will use a proxy of sales, and you could look at deaths from tobacco-related illness. That would be a much more nuanced analysis to try and unpick what's going on there.
Yeah, this question comes from the fact that we kind of look, like at the trends of obesity in Mexico, and they are going like steadily up, despite consumption of like sugar drinks and ultra processed foods going down. So yeah, there's something being substituted there in some way that we don't yet understand. But yeah, that's from where
let me follow up that, because I showed you at the beginning that forest plot, right, which shows really the proportion of different types of diseases. And what we see in pretty much every country, is that the proportion of all deaths attributable to NCDs is growing over time. But actually it's slightly disingenuous, because actually the rates of NCD deaths are actually going down in most places, because compared to 30 years ago, you're more likely to get aspirin if you've had a heart attack. But we're also doing much, much better at like reducing injuries and maternal mortality and that other stuff. So I think the story very broadly is that deaths from all causes and morbidity from all causes for everything in the world is going down as we get better at treating stuff, as we slowly get better at preventing stuff. But we've seen the most rapid improvements in the more traditional things that were in the Millennium Development Goals. And there's a bit of a lag with NCDs. So I wonder how much you were probably saying, though, like adjusted deaths are going up despite the fact that consumption is going down. But I just wanted to check that you didn't mean the relative proportion of all deaths attributable to NCDs were going down over time.
Yeah, no, it was more like the proportion of people with high body mass index is the one that was going up, like the risk factor.
Yeah. Despite, but at the same time, you think diet is improving and you think physical activity levels are either stable or improving.
Actually, like the effect of the policy is like the intended effect of diminishing the consumption or the sales of these nocive products is in place. However, we don't know if diet is improving, because maybe they are just like,
substitution effects. Yeah, I'm not going to drink a sugary drink, but I'm going to go and eat an entire cheesecake. Yeah.
So yeah. just
Sure.
putting that in the.
Yeah, and that's important because the cross price elasticities that are used to determine if someone drinks less fizzy drink, what else do they do? From Mexico, because of your sugary beverage tax, is so well known, are being applied all over the world. I've just examined a PhD based in the Philippines, where they've used Mexican data to estimate the number of lives that will be saved. So if you're seeing unexpected things there, it's got knock-on effects for the modeling being used all over the world.
Yeah, that's interesting. And maybe, it also makes me think that maybe we should focus more on like production-based taxes. So maybe even the sugar in the cheesecake will be taxed instead of consumer-based taxes.
Yeah.
Just an idea there.
I mean, I'd like to see, because the problem is so big and so many people are dying prematurely, we've got to use all of these different interventions, right? And I can see the time, so we're coming into land here, but the Nuffield ladder of public health interventions is something that I go back to often. And it's like, when you've got a problem, there are a range of things you can do, ranging from the least restrictive, do nothing, to the most restrictive, ban it, make it illegal, and stuff in between, like education, which is what libertarians always love doing, like inform people. Front of package labeling might be in their mass media campaigns, up to kind of nudges, to kind of softer incentives, to softer, harder disincentives like taxes and price signals, up to bans or restricting the ability of things. And we want to use the least restrictive but effective measure, and we often need to work through lots of different channels, at the national, at the regional, at the local, using the full gamut of things to try and maximize people's ability to do things that they enjoy, like having a sugary drink every now and again, without killing themselves and destroying society in the process. And that comes down to your national values, right? Yeah.
Okay. Well, thank you so much, Luke, for your time and leaving so much time. Yeah, enough for a really rich discussion.
Yeah, thank you so much for your everybody. It's been really great to have such great questions and a really engaged audience. So thank you for making it so fun.
Maybe you'll hear from us sometime later.
All right. Yeah. Thanks very much. All right, guys. Bye.
Bye.